Hello guys, I hope I'm audible to all of you. So welcome back to MedEd. I'm Dr. Patil, and in this video module we will be revising quickly basic concepts and points of nephrology. Well, for those who are giving the FMGE exam in the upcoming days, this is not an exhaustive review. This is not meant for someone who wants to study nephrology ground up or from the basics. This is for those who want a quick boost for the revision of nephrology. Okay, now from nephrology, what is important? I've listed 4 important topics. Actually, there are 5. Okay, I will tell you which one I am omitting here. The first one is symptomatology. You may be thinking why symptomatology is important, because whenever we deal with clinically oriented questions, right, we should be able to recognize कि हाँ इस question में इसी disease की बात हो रही है. That's why symptomatology is important. Otherwise, if you're good with the diagnostics and identifying the symptoms and making a diagnosis of the disease, then you can omit the revision of symptomatology. Second, a repeatedly asked MCQ template is either image-based questions or direct one-liner questions about urinary CAS. Then 2 most important topics from nephrology is acute kidney injury. Inside acute kidney injury, there is a diagnostic criteria which you need to literally memorize. There is no easy hacks. You need to by heart it. Then there is staging of acute kidney injury in 2 forms, KDIGO and RIFLE. You should be familiar with both of them. How to evaluate acute kidney injury, particularly under evaluation, you are expected to know how to differentiate between pre-renal acute kidney injury and acute tubular necrosis. That had been the MCQ template for several years, and it will continue to be an important MCQ template for the upcoming FMGE exam also. And then when it comes to chronic kidney disease, most importantly, the staging of CKD and complications. Complications are the areas of MCQs. But apart from these 4 topics, there is one more important topic, which is glomerular disorders. The post-streptococcal glomerulonephritis, right? Then various other forms of acute glomerulonephritis, RPGN. But most of the questions that are asked from the glomerular disorders come from pathology. There is hardly anything from medicine. That is why we are not wasting our time there. If you have done that topic from pathology, that is more than enough, right? So we'll start with the symptomatology first, because that will help us to recognize diseases, right? Now, when we talk about the symptoms of renal dysfunction, the symptoms not only help us identify that हाँ इस patient में kidney का कोई problem है, but they will also help us to localize कि kidney के कौन से structure में problem है. We all know that nephron is the structural and functional unit of the renal system, and in the nephron we have various parts, right? We have glomeruli, right? And then we have the tubules, right? Tubules include proximal convoluted tubule, distal convoluted tubule, a loop of Henle which has a descending and ascending limb, and then we have the collecting ducts. Right? So when we say that kidney is dysfunctional, right, it means the problem may be in the glomeruli. If the problem is in the glomeruli, that is what we call as glomerular disorders or glomerulonephritis, right? Then the problem may be in the tubules, right? So if it is in the tubules, we will call it as tubular disorders, right? Apart from the nephrons, there is also connective tissue which is holding all these nephrons together. That is what we call as renal interstitium. So in terms of disease localization, a kidney disease may be because of the problem in glomeruli, problem in the tubules, or problem in the interstitium, right? So going forward, I want you to learn how to identify a glomerular disease, a tubular disease, and an interstitial disease. Okay, so we'll start with the symptoms first. What all symptoms we can expect when somebody's kidney is affected by the disease? One, as function, kidneys produce urine, and if there is an issue with the kidney, urine output may be varying. So first thing is we should know what is the normal urine output. Normal urine output is more than or equal to 0.5 ml per kg per hour. That is the normal urine output, right? So anything less than that is counted as abnormal. So if there is a 50 kg person, right, 0.5 ml per kg per hour, that should be the normal urine output for anybody, right? We can easily calculate what is expected normal urine output for a 50 kg person or a 60 kg person by looking at this number. Now, what abnormalities of urine output we can expect? Urine output can either increase or decrease. When it increases, we call it as polyuria, right? So they will ask you, when do you call it as polyuria? We know that 0.5 ml per kg per hour is normal urine output, right? So when the urine output is more than or equal to 40 ml per kg, please remember this is where they try to confuse you. It is per day or per 24 hours. So in 24-hour period, if the total urine output of an individual is more than 40 ml per kg, then we will call the patient as having polyuria. For example, if I'm dealing with a 50 kg person and my urine output is, let me say, 2.5 liters in 24 hours, do I have polyuria by definition? 40 ml per kg into 50 kg, that becomes 2000 ml or 2 liters. So if I am producing more than 2 liters of urine per day, then we will say that I have polyuria. Okay. Decreased urine output, we have two terminologies here. One is called as oliguria, the other one is called as anuria. Oliguria, in simple words, yes, decreased urine output, but there is an objective number. When the urine output is less than 400 ml per day, not per kg per day. Please remember, this is where they confuse you. Normal urine output is 0.5 ml per kg per hour or more. When in 24-hour urine output is more than 40 ml per kg, then it is polyuria. In 24 hours, if the urine output total is less than 400 ml, we will call it as oliguria. And we will call it as anuria when the urine output in 24 hours is less than 100 ml. When it is less than 100 ml, we will call it as anuria. All these three terminologies can be directly asked as MCQs. Which of the following defines anuria, oliguria, polyuria, or normal urine output? Okay. Now, the second thing, a patient with kidney disorders may present with dysuria, increased frequency of urination or urgency. And if these symptoms present, then we know that we are dealing with a case of urinary tract infection, right? Similarly, if there is a question which is talking about a patient having periorbital edema, right? Edema around the eye region, presence of hematuria, proteinuria and hypertension. What should come to your mind? It should point towards what you call as nephritic syndrome. You may be familiar that there are two types of glomerular pathologies. One is called as nephrotic syndromes and nephritic syndromes. What is the main difference? In the nephritic syndrome, apart from the proteinuria, you also have hematuria and you have classical periorbital edema. In nephrotic syndrome, you can have all the same symptoms, but most importantly, the proteinuria will be much higher and the hypertension, the severity of hypertension is slightly lower, right? So if you see a patient with periorbital edema, hematuria and proteinuria and hypertension, think of nephritic syndrome. And whenever you have nephritic syndrome, it means the disease is affecting what? It is affecting the glomeruli. So it is a glomerular disorder. Glomerular disorder. So if I say that, okay, here is a patient who had sore throat, right? 2 to 3 weeks later, he presented with periorbital edema, hematuria, proteinuria and elevated blood pressure. Two things this story tells. First thing, this story tells that this patient is suffering from a glomerular disorder. That is what we call as glomerulonephritis, right? He had a throat infection 2 to 3 weeks back. So that is pointing towards a post-streptococcal glomerulonephritis, right? Okay. Point to note here is that the hematuria that we see here in patients with the glomerulonephritis, right? The nephritic syndrome, it will also have RBC casts. In addition to the blood in urine, they can have RBC cast and they can also have dysmorphic RBCs. Please remember, presence of dysmorphic RBCs is the hallmark of glomerular disorder. Any question that says that the RBCs are dysmorphed means उनका shape बिगड़ गया है in urine. ब्लड में ठीक है लेकिन यूरिन में शेप अल्टर्ड हो गया है, इसका मतलब डैमेज इज टू द ग्लोमेरुलाई. जब डैमेज ग्लोमेरुलाई से आरबीसी पास होके निकल रहे हैं, उसका शेप डिस्टॉर्ट हो रहा है, राइट? ओके. एंड इफ यू गेट अ पेशेंट और अ क्वेश्चन वेयर द पेशेंट स्टोरी इज दैट ही हैज गॉट फ्लैंक पेन, राइट? दैट इज द लोअर बैक पेन. along with that, graveluria. Gravel means tiny stones, right? So in the urine he has tiny stones and he has hematuria. All of this is pointing towards renal calculi. So patient may be having stones. Okay. The last one, if you have a patient who is complaining of decreased appetite, nausea, severe vomiting and his kidney function test, the creatinine and urea are altered. All of this is pointing towards elevated blood urea level. So please remember, when blood urea level increases, patients have severe intolerance of food. They will have severe nausea and vomiting. So any patient with kidney disorder, when they have severe nausea, vomiting, first thing as a doctor we should think of is elevated urea levels. So these are some clinically oriented, clinical vignette type of questions that they can ask, and now we know how to recognize, right? If you have a patient with dysuria, frequency, urgency, UTI, Periorbital edema, hematuria, proteinuria, hypertension, especially hematuria with dysmorphic RBCs, RBC cast, think of nephritic syndrome. If there is flank pain, graveluria and hematuria, think of renal calculi. Loss of appetite, nausea, vomiting with altered RFT, think of urine. Okay. Now we will spend some time talking about the hematuria, and then we will also talk a little bit about proteinuria, because I have already told you we have two types, the nephrotic syndrome and nephritic syndrome, and the distinction mainly lies on the degree of proteinuria. So we will go there. So first thing is, what is hematuria? Presence of RBCs in urine. But we need to have an objective definition. So when we get more than or equal to 3 RBCs per high power field on microscopy, then we call it as hematuria. So this is a potential MCQ point. To call it as hematuria, how many RBCs should be there in each high power field under the microscopy? So 3 or more than 3. Okay. But hematuria need not always mean it is significant, right? So to call it as significant hematuria, if any of these 3 parameters are met, then we call it a significant hematuria. One of them is gross hematuria. Now what do I mean by gross hematuria? Gross means visible hematuria. I don't need to see under the microscope. Directly blood ही दिख रहा है urine में, right? Patient came and told that I'm passing blood in urine. That is gross hematuria. उतना blood urine में जा रहा है तो significant होगा ही, right? Second is more than 100 RBCs per high power field on a single sample. किसी भी sample उठा लो, एक sample में आपको 100 से ज़्यादा RBCs हर high power field में microscope के अंदर दिख रहे हैं तो that is significant. But if these two criteria are not there, then to call it as significant, we need to have the RBCs more than or equal to 3 RBCs per high power field. That was our definition of hematuria on at least 3 separate samples. When I say separate, it means not कि हाँ एक बार urine pass करो और 3 sample लो और तीनों में RBCs ढूंढो. No, 3 different times you collect the urine specimen and तीनों में आपको 3 या 3 से ज़्यादा RBCs मिल रहे हैं per high power field, then it is significant. And this parameter is also known as persistent hematuria. Persistent hematuria. So persistent hematuria significant है, more than 100 RBCs per high power field on a single sample भी significant है, और macroscopically visible hematuria भी significant है. Okay. Now coming to proteinuria, right? Proteinuria में क्या questions पूछेंगे? When do you call it as transient proteinuria? When do you call it as orthostatic proteinuria? When do you call it as persistent proteinuria? Okay. क्योंकि persistent proteinuria significant है, बाकी benign है, right? The transient proteinuria and orthostatic proteinuria are benign. They do not indicate any medical disorder. Okay. What is transient proteinuria? As the name says, transient मतलब कभी कभी patient की urine में protein दिख सकता है. कब हो सकता है? After exercise. When you do exercise, right, you break down your muscle, और muscle से जो protein leak हो रहा है, some of that might get filtered in your urine. When you have fever, right, when you have fever, during that time also there can be tissue breakdown and you can have some degree of proteinuria. But ये fever के बाद persist नहीं करेगा, right? आज मैंने severe exercise किया जिम में तो शायद आज मुझे proteinuria होगा, परसों या 3-4 दिन बाद persist नहीं करेगा. So that's why we call it as transient proteinuria, which is benign. No need for further investigation, right? Orthostatic proteinuria क्या है? Proteinuria on long standing. If you stand for a long period of time, right, like आप कंडक्टर हो या बस में खड़े हो, बस में आपको बैठने की जगह नहीं मिली है, you have to stand for 3-4 hours to travel to reach your destination, तब for next few hours you might have proteinuria. That is also normal, right? So when do we call it as persistent proteinuria? When proteinuria is present on more than or equal to 2 samples. More than or equal to 2 samples, then we call it as persistent proteinuria. Persistent proteinuria significant है, important है, right? आज एक sample लिया, proteinuria positive है, 2-3 दिन बाद फिर से लिया, तब भी proteinuria है, तो then it is significant. अगर ये orthostatic होता तो शायद आज होगा, क्यों परसों होगा या 2 दिन बाद क्यों होगा? If it was because of fever or if it was because of some other causes, it would have settled by then. But 2 samples taken separately, if proteinuria is persistent, then we call it as persistent proteinuria. It is significant. So जब हमको persistent proteinuria मिलता है, right, we need to differentiate whether this protein loss is happening from the glomeruli or whether it is happening from the tubules. मतलब क्या है? Normally, when we filter the urine, right, into the Bowman space and then it will pass through the proximal convoluted tubule, loop of Henle, distal, and then collecting ducts. we will not be filtering the proteins much, right? But when there is a damage to glomeruli, the proteins may be lost in the convoluted tubules, right? And then it will be lost to the urine. Sometimes क्या होता है जब there is damage to the tubules itself, मतलब proximal convoluted tubule को, या there is damage to distal convoluted tubule, loop of Henle. In that case, the leakage of proteins might happen from the damaged tubules, right? So we need to differentiate whether this protein is coming from the glomeruli or whether it is coming from the tubules. How do we differentiate whether a particular individual has a glomerular proteinuria or the tubular proteinuria? The important point to note here is when you have glomerular proteinuria, you will have albumin in your urine because the albumin gets filtered when there is a damage to glomeruli. So whenever you have albumin in addition to other proteins, when you have albuminuria, that is equal to glomerular proteinuria. And if you have no albumin but other proteins in the urine, then it is tubular. So in the tubular proteinuria, there will be no albumin. That's the point, right? So can you differentiate now between proteinuria because of damage to tubules and proteinuria because of the damage to the glomeruli? Yes, if there's a damage to glomeruli, you will have albumin. And there are specific tests, as you know from biochemistry, to recognize albumin. अगर यूरिन में albumin है तो damage glomeruli में है. यूरिन में albumin नहीं है लेकिन बाकी proteins है तो damage tubules में है, right? Examples for the tubular injury that can cause proteinuria, well, we have a long list like multiple myeloma, right? Renal tubular acidosis, certain drugs, and the examples for glomerular proteinuria, all the glomerular disorders like post-streptococcal glomerulonephritis, IgA nephropathy, membranoproliferative glomerulonephritis, anti-glomerular basement membrane antibody disorder, right? All the glomerular disorders will cause glomerular proteinuria. Okay. So far what we have learned: hematuria as a symptom, urine output as a symptom, and proteinuria as a symptom. Okay. Now coming to the more detailed discussion on the proteinuria. When there is damage to glomeruli and we have proteinuria, basically we have albumin in urine. How do we further evaluate, right? So when we are thinking of the patient with glomerular proteinuria, we will divide them into microalbuminuria, macroalbuminuria, and a nephrotic range proteinuria. If you have nephrotic range proteinuria, that points towards having nephrotic syndrome. If you have micro or macroalbuminuria, that points towards nephritic syndrome, right? Now, what is the best way to record the amount of albumin lost in urine? Either we can ask the patient to collect 24-hour urine and estimate the amount of albumin, or alternatively, we can do what is called as urine albumin create ratio. Urine albumin create ratio means instead of collecting 24-hour sample of urine, which is complex, right? मतलब किसको होगा? If you tell me that okay, एक बोतल लेके जाओ और कल तक जितने बार यूरिन आपको पास करने का फील होगा तब तक हर बार एक बोतल में ही पेशाब करते रहो और सारा जो कलेक्शन है अगले दिन आके दे जाओ. Very cumbersome, right? Not easy. So instead what we do is we take a single sample of urine and check how much albumin is there in the urine and how much creatinine is there in the urine. This is what we call as urine albumin create ratio. This is what is most commonly practiced today. Okay, so based on this 24-hour urine albumin and USCR, how do we divide? Okay, so the normal urine albumin excretion in 24 hours is less than 30 milligrams per day. Means in 24 hours we excrete less than 30 milligrams of albumin in urine. Anything more than that is abnormal, right? Now if I look at the urine albumin create ratio, it is pretty easy to remember. आपको same number याद रखना है, that is going to be 30. Means 1 gram of creatine passed in urine, you would be passing less than 30 milligrams of albumin. So usually we abbreviate it as 30 milligrams of albumin for every gram of creatinine passed. Okay, so if this 24-hour urine albumin is in the range of 30 to 150 milligrams per day, right? 30 to 150 milligrams per day, or UACR, urine albumin create ratio, is 30 to 150. In that case, we will call it as microalbuminuria. microalbuminuria. Okay, anything higher than this will be called as macro. So 24-hour 150 to 3.5 grams, 150 milligrams to 3.5 grams, or okay, see the main reason why it is seen in periorbital region, we will see the edema even in the pedal region, but periorbital edema becomes easily recognizable. See, please remember, in a nephritic syndrome patient, the edema is not gross. It is not like you see a patient with chronic heart failure or a patient with CLD where the edema is gross and it is gravity dependent. But in patients with the nephritic syndrome, the edema is minimal. So it is more easy for a patient to recognize in the periorbital region, and that is how they present to hospital. On examination, you might get the pedal edema also. Okay, so then when UACR is in the range of 30 to 30 milligrams, 150 milligrams to 3.5 grams, 150 milligrams to 3.5 grams, we will call it as macroalbuminuria. When it is more than 3.5 grams, the 24-hour urine albumin is more than 3.5 grams, for every gram of creatine passed in urine, we will call it as nephrotic range. So UACR and 24-hour, the numbers are same. No need to get confused there. Okay. So if you have a nephrotic range proteinuria, you think of those glomerular disorders which cause nephrotic syndrome. Example being diabetic nephropathy, focal segmental glomerulosclerosis, right? Minimal change disease. Then when you have micro or macroalbuminuria, you think of those glomerular disorders which cause nephritic syndrome, like post-streptococcal glomerulonephritis, right? So that helps us to differentiate. Okay. So with this basic backdrop, we'll start with the most important chapter, that is the urinary cause. So normally what happens when we filter urine, right? When we filter urine, we are only filtering basically we're filtering the plasma, right? And from that plasma, we will reabsorb most of the required electrolytes and substances and as much required water, right? Rest of the things and unwanted waste we will end up excreting in the urine. Okay. But now when this urine passes through the tubules, right? Tubules have the epithelial lining, right? Sometimes those epithelial cells may be shed, right? Similarly, though we will not be filtering most of the proteins, some amount of low molecular weight proteins may be filtered, which will be lost in urine. So those proteins is what we call as Tom Horsfall proteins. So we lose some amount of Tom Horsfall proteins in urine and some amount of epithelial cells from the renal tubules. Okay. But these Tom Horsfall proteins, as they pass through the tubules, right, they spend some time in the tubules and they assume the shape of the tubule. Like they become like tubes, right? And then we excrete those tubes in the urine. These tubes is what we call as hyaline cast, right? So normally when we say cast, some substance is visible under the microscope, and regardless of what type of cast it is, right, its skeleton is made of hyaline cast, and the hyaline cast is made of Tom Horsfall protein. Tom Horsfall proteins. Okay. The casts are divided into two groups, the cellular cast and non-cellular cast. So when you say cellular cast, मतलब ये Tom Horsfall protein का एक जो ट्यूब बना है उसमें cells भी ऐड हुए हैं. एंड व्हेन यू से एसेलुलर कास्ट मतलब क्या है, ये टॉम हॉर्सफॉल प्रोटीन का सीट है, उसमें कुछ और सब्सटेंसेस या केमिकल्स ऐड हुए हैं लेकिन सेल्स ऐड नहीं हुए हैं, राइट? देन वी कॉल देम एज एसेलुलर कास्ट. जस्ट टू गिव यू समरी अगेन, ये मेरा एक ट्यूब्यूल है जहाँ पे टॉम हॉर्सफॉल प्रोटीन अक्यूमुलेट होके एक ट्यूब के जैसा बन गया, राइट? अगर इसके ऊपर मैं आरबीसीज भी इम्प्रेगनेट कर दूँ तो उसको हम कहेंगे आरबीसी कास्ट. अगर इसके ऊपर मैं डब्ल्यूबीसीज को लोड कर दूँ तो वी विल कॉल इट एज डब्ल्यूबीसी कास्ट, राइट? अगर इसके ऊपर सेल्स के बदले इफ आई ऐड सम फैट ग्लोब्यूल्स, राइट, इफ आई ऐड सम फैट ग्लोब्यूल्स, देन वी विल कॉल इट एज फैटी कास्ट, राइट? So basic question they will ask you is the cast, skeleton of the cast is made of what? It is made of, the skeleton of the cast is made of Tom Horsfall proteins. Tom Horsfall proteins. Okay. Your drug of choice? Sure. Yeah. Okay. Now cellular cast, we have RBC cast, WBC cast, then renal tubular epithelial cast and muddy brown cast. Non-cellular cast, we have hyaline cast, granular cast, fatty cast and broad or waxy cast. What MCQs they will ask you? First one, they might give you a cast and ask you to identify which kind of cast it is. Second, they might give you a cast and then they will ask you in which condition it is seen, right? Third, they might ask you what is the most common cast, right? The most common cast is hyaline cast. Hyaline cast is the most common cast which is seen in normal individuals. Whoever excretes urine will excrete some amount of Tom Horsfall protein. ये Tom Horsfall proteins cast बनाते हैं. So if I give my sample or you give your sample, the microscopy might show hyaline cast that is seen in normalcy, right? So this is how it looks like. A thin hyaline or translucent sheet, right? This is what we call as hyaline cast. So under the microscope, if you see as translucent sheet, that is hyaline cast. It is seen in normal individuals. It indicates that you don't have any major problem as such. Okay. Now on top of this hyaline cast, if I add fat globules, then it becomes fatty cast. In what condition I will have excretion of fat in urine so that fat molecules get impregnated on these naturally formed hyaline casts? Where do we have lipiduria? That's the question, right? Where do we get lipiduria? Can anybody list the diagnostic criteria for nephrotic syndrome? One criteria I've already told you. The urine protein excretion or albumin excretion more than 3.5 grams per day or more than 3.5 grams of albumin for every gram of creatinine excreted in urine. Yes, fat embolism is one, but more common than that. Fat embolism is a very rare phenomenon. More common than that. So in nephrotic syndrome, one of the diagnostic criteria is also excreting lipids. Nephrotic syndrome, we can have lipiduria. Other than that, prothrombotic state, increased risk of developing the clots or thrombosis is also part of the nephrotic syndrome. So fatty casts are typically seen in nephrotic syndrome because there is lipiduria. Because in nephrotic syndrome, we excrete lipid in urine. There is lipiduria. We have hypercholesterolemia as well as if cholesterol in the blood is high, cholesterol and the lipids in the urine will be high. Those lipids will go and get impregnated in the cast, giving you a hyaline cast becoming a fatty cast. Okay. Then we have RBC cast. Means look at this image. Right? You can see that there is a skeleton made of the Tom Horsfall protein. On top of that, plenty of RBCs are loaded. When will that happen? When RBCs reach the tubules. Please remember where the casts are formed. Casts are formed in the tubules. Right? These Tom Horsfall proteins are spending some time. They precipitate and form the cast. They take the shape of the tubule. So they are formed in the tubule. अगर ट्यूब्यूल में इस कास्ट में RBCs पहुंच रहे हैं, right? तो कहाँ से आ रहे हैं? From where they are coming? They have to come from the glomeruli, right? When there is a glomerular injury, the RBCs will leak. I think we have already studied about it, right? Whenever we have hematuria, it points towards glomerular disorder, right? I told you hematuria points towards glomerular disorders. So if there is an injury to the glomerulus, the RBCs will be released or leaked into the urine. These RBCs, when a cast is being formed, they will get all impregnated on it, and thus we will end up getting a RBC cast. So whenever we have an RBC cast, it indicates that we have glomerulonephritis or glomerular diseases. In addition to that, these patients' urine will also have dysmorphic RBCs. Means not just the RBC cast, they will have RBCs which have altered shape. We will call them as dysmorphic RBCs. Presence of dysmorphic RBCs is counted as the hallmark of glomerular disorders. Okay. Then WBC cast. For me to form the WBC cast, WBCs need to reach the tubules. Hyaline cast तो बन ही जाता है, उसके ऊपर WBCs भी बैठना चाहिए, right? Hyaline cast would have been already formed. Now WBCs need to get impregnated on it. From where the WBCs will come? When there is infection to the kidney. We call that condition as pyelonephritis. So when you have pyelonephritis, you can develop WBC cast. Okay. Then we have an entity called as RTEC cast, which stands for renal tubular epithelial cell cast. Renal tubular epithelial cell cast. So basically what happens, you have this hyaline cast, on top of that the renal tubular epithelial cells get deposited. So where should be the damage for us to get this? To get the epithelial cast, like you see here, you can see these epithelial cells. Tubules को damage होगा तभी epithelial cells will be shed, right? So whenever you have renal tubular epithelial cast, it indicates that you have acute tubular necrosis or injury to the tubules, renal tubules. Okay. Then we get one more entity called as muddy brown cast. It is nothing. यही है renal tubular epithelial cast. Over time, what happens? All these epithelial cells which were shed from the tubules are now deposited on the hyaline cast, right? They will get into apoptosis, right? They go through the degenerative changes. और उस टाइम पे there will be production of a pigment called as lipofuscin, and because of this lipofuscin pigment, now the cast starts looking brownish. That is what we call as the muddy brown cast, right? It looks like mud and it is brownish, so we call it as muddy brown cast, which also indicates that one patient has got acute tubular necrosis. Acute tubular necrosis. Okay. Then we have another entity called as granular cast, where there is a hyaline membrane. On top of that, a granular substances are deposited. Basically, these are all different proteins deposited on the hyaline membrane cast. This is what we call as granular cast, which can happen if there is a damage to tubules, you fail to reabsorb some substances, or when you have chronic kidney disease. Granular casts are seen in acute tubular nephrosis and chronic kidney disease. Okay. The last and equally important cast is what we call as broad and waxy cast. Broad मतलब थोड़ा सा wide है and wax के जैसे दिखता है, right? It is not looking like the hyaline cast that we had seen, right? Which was translucent. This looks more like wax. This is what we call as broad and waxy cast. These are typically seen in patients with chronic kidney disease. In patients with chronic kidney disease. Now cast एक बहुत ही important topic है. Means almost every alternate exam there will be a question on cast. So what we will do is we will quickly revise these points, right? Let us say if we can, let's see if we can match it, right? Let us have a question. Match the following. Okay, so on one side we will have 4 conditions. Let me say glomerulonephritis, then chronic kidney disease, then nephrotic syndrome, then muddy brown cast. Okay. And on the other side we have broad waxy cast. Now among the options, which one this will match with? The broad waxy cast, fatty cast, RBC cast, and acute tubular necrosis. Good. So for glomerulonephritis, ideal thing would be to go ahead with the RBC cast, right? When there is glomerular injury, we will have hematuria. Those RBCs are getting impregnated on the hyaline cast. The best thing that we could pick up for CKD here would be to go ahead with the broad waxy cast, right? For nephrotic syndrome, we just learned that there will be lipiduria, so we will be excreting lipid in urine, and that may also get impregnated on the hyaline cast, giving rise to fatty cast. And then muddy brown cast is nothing but renal tubular epithelial cell cast, where the cells have gone into apoptosis, degenerated, producing lipofuscin pigment, giving rise to brown color. That is typically seen in acute tubular necrosis. Right? Good. So please remember, this is a potential MCQ zone. Okay. So now coming to the crux of nephrology, the acute kidney injury and the chronic kidney disease. From acute kidney injury, you need to by heart the diagnostic criteria, which is called as KDIGO criteria. There are two levels of staging, the KDIGO staging and the referral criteria. And third, you need to differentiate between acute tubular necrosis and the pre-renal acute kidney injury, right? So what is acute kidney injury? It refers to the damage to the kidneys in a very short span of time, right? The ideal diagnostic criteria is what we call as KDIGO criteria. According to that, you can say someone has got acute kidney injury if out of the three mentioned parameters, any one is met. The first two parameters are based on the creatinine, right? So these are based on change in the creatinine that is happening, and the last one is based on the change in urine output, Okay, so a person will be called as having acute kidney injury if his serum creatinine increased by more than or equal to 0.3 milligrams per deciliter within a span of 48 hours. Both these numbers are important, right? They might ask you which of the following is not as per the KDIGO criteria for the diagnosis of acute kidney injury, right? यही numbers होंगे, क्या flip करेंगे? 0.3 milligrams per deciliter को alter करेंगे या 48 hours they will change, right? They will just, instead of 48 they will say for 24 hours or 72 hours, right? This they may change to 0.5 milligrams per deciliter. Inside nephrology there are a lot of numbers that can confuse, right? Just to give you an example, normal urine output क्या है? The normal urine output is 0.5 ml per kg per hour or more, right? So this 0.5 is already there in our mind. In the examination hall, I see an option which is saying that rise in creatinine by more than or equal to 0.5 milligrams per deciliter. I might think, हाँ यही तो number मैंने देखा है, right? So that is why I say in nephrology we need to by heart the numbers. Concepts नहीं है, we have to by heart the number. So if the creatinine rises from whatever it was, right? Normal is 0.8 to 1.2 milligrams per deciliter, but I may already be having a kidney dysfunction, so it may be higher, right? Let me say मेरा 2 था already, 2 milligrams per deciliter था. From there it has become, let me say 2.4 milligrams per deciliter in less than 48 hours, right? So definitely there is more than 0.3 milligrams per deciliter jump in a span of time less than 48 hours. Then I will call it as acute kidney injury. Or if the creatinine increases by more than 50% in less than 1 week, means to start with, let me say it was 1, right? It has gone to become 1.6 in less than 1 week, right? कितना percent jump हुआ? कितना letter jump हुआ? कितना percent jump हुआ? From 1 to 1.6, 60% in less than 1 week. So it satisfies this criteria. Yes, then also I will call it as acute kidney injury, right? And the third one is the urine output criteria. Inside the hospital, most of the patients with acute kidney injury get recognized because of the drop in urine output. Like, see, commonly you hear, right? Someone got admitted with loose stools, then फिर डॉक्टर बोल रहे हैं कि kidneys have gone into shutdown. अब डॉक्टर को कैसे पता चला? Because same day सुबह एडमिट हुआ है, शाम को डॉक्टर बोल रहे हैं kidneys are not working, right? How do we get to know? Because if regular criteria follow करेंगे तो 48 hours का time लगेगा to see the jump in creatinine, या मुझे baseline creatinine पता होना चाहिए, right? Or sometimes we end up diagnosing the acute kidney injury over several days. Urine output criteria is the one which helps us to quickly recognize acute kidney injury in hospitalized patients. So if urine output is normally 0.5 ml per kg per hour or more, when it is less than this number for 6 hours or more, then we will call it as acute kidney injury, right? Now this is the KDIGO criteria. KDIGO also goes on to stage the acute kidney injury into 3 stages. So first stage is when, same again, urine output and creatinine will come into picture, right? If the creatinine is 1.5 to 1.9 times the baseline, or creatinine increases by more than 0.3 milligrams per deciliter, यही तो हमारा criteria था for diagnosis. That will be stage 1. Or if the urine output is less than 0.5 ml per kg per hour for 6 to 12 hours. 6 hours तक तो चाहिए to call it as acute kidney injury, right? उसके बाद में staging start होगा. To call it as acute kidney injury, at least for 6 hours the urine output should be less than 0.5 ml per kg per hour. ये इतना low output 6 से 12 घंटे तक persist कर रहा है तो then we will call it as stage 1. अगर ये 12 घंटे से ज़्यादा है तो then we will call it as stage 2. Similarly, starting point creatinine जो भी था उससे 2 to 2.9 times बढ़ गया है तो then it will be called as stage 2, right? And then अगर ये 3 times or more there, more than the baseline, whatever was the starting point, let me say starting point was 2 milligrams per deciliter, now it has become 6, right? So it is 3 times more than the baseline. If that happens, then it will be called as stage 3. Or the urine output dropping to less than 0.3 ml. Confusing point, please pay attention. Stage 1 or stage 2 urine output criteria simple है. Less than 0.5 ml per kg per hour, 6 to 12 hours stage 1, right? 12 hours or more stage 2. But if it is less than 0.3, 0.5 नहीं, less than 0.3 ml per kg per hour for more than 24 hours, then we will call it as stage 3. और anuria, anuria का मतलब क्या है? Total urine output less than 100 ml in 24 hours. That's the basic definition of anuria. अगर anuria है for 12 hours or more, that will also be counted as stage 3, right? And whether it is acute kidney injury or chronic kidney injury, any patient who goes on dialysis will always be counted as the highest stage. AKI में highest stage here is 3. So if you have to start dialysis, it will be counted as stage 3. CKD में there are 5 stages. So if someone is on dialysis, he will be counted as stage 5. Okay. Now we have one more criteria which is called as Ripple criteria or Riffle staging, which refers to the first stage is called as risk, second stage as injury, third stage as failure, fourth as loss, and the last one is end stage kidney disease or CKD. Okay. This is also easy to remember. What is it? Instead of having the creatinine criteria, they have the GFR. Urine output criteria is standard, right? They have introduced GFR. Creatinine is there, but they have introduced the GFR and urine output is there. Okay. So what is risk? Risk stage is nothing but stage 1 of the KDIGO stage. Stage 1 में क्या था? Creatinine बनता है 1.5 to 1.9 times the baseline. So same applies here when the creatinine is more than 1.5 times the baseline. When it is more than 2 times the baseline, that becomes stage 2 according to KDIGO. That becomes injury according to the Riffle criteria, right? And what was the third one? When the creatinine is more than 3 times the baseline. So when the creatinine is more than 3 times the baseline, that will become failure. Urine output criteria भी तो same ही है, right? Less than 0.5 ml for 6 hours to 12 hours, 12 hours or more, or less than 0.3 ml per kg per hour for 12 hours, or anuria for 12 hours. So it is same, right? KDIGO and this is not different for first 3. So all you need to remember is, according to Riffle, stage 1 will become the risk category, stage 2 will become injury category, and stage 3 will become failure category. That will become failure. Only 2 things that next extra come into the Riffle criteria is loss and end stage kidney disease, right? What is loss? ये जो भी है, right? मतलब risk category, injury category या failure category, if it is persisting for more than 4 weeks, right? Creatinine more than 1.5 times the baseline, या 3 times the baseline, 2 times the baseline, whatever it is, or urine output less than 0.5 ml per kg per hour, whatever risk, injury or failure, if it is persisting for more than 4 weeks, then we will call it as loss, right? And if it is persisting for more than 3 months, then we will call it as end stage kidney disease or CKD. Garam masala, that's a good point, right? See letters 0.3 and 0.3. That's a good way to remember it. Okay, ये थोड़ा सा आपको शायद by heart करना पड़ेगा, but it is worth spending 10 minutes of your time to remember this, because इसके ऊपर बार-बार questions आते रहते हैं. Okay, so we now have understood what is acute kidney injury and how to stage it. Now what we need to understand? We need to understand the causes for acute kidney injury. What can cause the injury to the kidney in an acute manner? The causes for acute kidney injury will be divided into 3 groups, as you know, right? We call them as pre-renal acute kidney injury. मतलब problem kidney में है ही नहीं. Kidneys receive the blood supply from the renal artery, right? If kidneys are not getting sufficient blood supply, तो वो काम कैसे करेंगे? They can't do a good work. Because of that, they will not be able to produce urine, they will not be able to clear creatinine, they will not be able to clear urea. So urea, creatinine सब बढ़ने लगेगा, urine output घटने लगेगा. So when the problem is not in the kidney, but the blood supply to kidney is reduced, we will call it as pre-renal AKI. Then we have intrinsic renal AKI, which refers to problem in the kidney itself, right? Matlab glomeruli or the tubules are damaged. That is what we call as glomerulonephritis, tubular disorders, or interstitial nephritis. Third thing what can happen is, if blood supply to kidney is fine, kidneys work fine, they filter creatinine, filter urea, right? But then outflow of urine from the kidney gets obstructed. फिर भी तो किडनी का एंड रिजल्ट ठीक से नहीं हो पाएगा, राइट? द यूरिन आउटपुट विल स्टिल कम डाउन बिकॉज वी आर प्रोड्यूसिंग बट नॉट एबल टू एक्सक्रीट इट बिकॉज ऑफ द ऑब्स्ट्रक्शन. And then there will be back pressure on the kidney, and that can cause further damage to the kidney. So such conditions we call as post-renal AKI. Post-renal AKI. Okay. So pre-renal AKI, what is the most common cause, will be an MCQ. The most common cause for pre-renal AKI is hypovolemia. So whenever you have severe loose stools, right, all these patients with cholera or like blood loss, they develop acute kidney injury. क्यों हो रहा है? Because of hypovolemia, right? Second thing that can happen is when you have decreased cardiac output, obviously you will not be able to give. See, when circulating blood volume is less, kidney gets less blood supply. When cardiac output is decreased, even blood volume ठीक है, लेकिन फिर भी blood supply kidney को नहीं मिल रहा है, kidneys cannot work. So when decreased cardiac output leads to renal dysfunction, a classical example I can give you is what you call as cardiorenal syndrome. Cardiorenal syndrome. Okay. Then the third one is decreased effective circulating volume. मतलब टोटल बॉडी वॉल्यूम और फ्लूइड कंटेंट तो नॉर्मल ही है, लेकिन जो सर्कुलेशन में है वो कम हुआ है, राइट? इन व्हाट कंडीशंस दैट कैन हैपन? व्हेन यू हैव हार्ट फेल्यूर, लिवर फेल्यूर, राइट? In such conditions you can have decreased effective circulating volume. तो वॉल्यूम कहाँ पे है? वॉल्यूम इज इन थर्ड स्पेसिस, मतलब प्लूरा में प्लूरल एफ्यूजन बन गया है, that has caused ascites, that has caused edema, but in circulation the volume is less. Okay. Then another important condition that can cause pre-renal AKI is the impaired renal autoregulation. Now kidneys regulate how much blood with what pressure gets into the glomeruli, and that is very crucial, right? To give you an example, let me say this is the glomerulus, right? And I have this Bowman's capsule here and the proximal convoluted tubule, right? So as we know, it has an efferent arteriole, right? And an afferent arteriole. So from afferent, the blood will come into it, and from the efferent, the blood will go out, right? Now whatever pressure that builds inside the glomerulus is the main driving force for the filtration process. Okay. Now if the amount of blood coming to the glomeruli is less, so the pressure that builds up in the glomeruli will be less, so I will not be able to filter properly, तो फिर किडनी का काम ठीक से नहीं चल पाएगा. Now in such conditions, what kidneys should do? What kidneys can do is they will dilate the afferent arteriole and constrict the efferent arteriole. So if I constrict the efferent arteriole, if the efferent arteriole becomes narrow and afferent arteriole becomes dilated, so in that case more blood can come inside. The exit of blood is hampered by the constricted efferent arteriole, so I will generate more pressure in the glomeruli and I will still be able to continue the filtration process. But how do we achieve that? What causes the afferent arteriole dilation? The afferent arteriole dilatation is mainly caused by prostaglandins, and efferent arteriole constriction is mainly caused by the angiotensin 2. So if I give someone, right, angiotensin receptor blockers or AC inhibitors where angiotensin production will be impaired, so in such cases I may not be able to cause the efferent arteriole constriction. That is why we know AC inhibitors can sometimes cause rise in creatinine. Why do they cause? Because they block the angiotensin 2 production. Now all of us know that NSAIDs cause kidney injury. One of the mechanism is when we give someone NSAIDs, we will decrease the production of prostaglandins. So if we are not able to produce prostaglandins, then we will not be able to cause the afferent arteriole dilatation. अगर किडनी में थोड़ा सा भी blood flow कम हो जाता है, we don't have any defense in such situation when we are using NSAIDs, right? So impaired renal autoregulation could be because of angiotensin receptor blockers or AC inhibitors, which will reduce the angiotensin 2 production or its action, and another one is NSAIDs. Right. Okay, now this is about the pre-renal AKI. In what all conditions the kidney blood flow gets reduced? When volume of circulating blood itself is reduced, right? Or the ability of the cardiac contraction is reduced, or effective circulating blood volume is reduced, or renal autoregulation is impaired by drugs like ACE inhibitors, ARBs, or NSAIDs. I will share this. I will share the PDF. Okay. Then when we say intrinsic renal, the problem is inside the kidney, right? So that can be because of either acute glomerulonephritis, like your post-streptococcal glomerulonephritis, right? That anyway we know how to recognize that history of sore throat and typical nephritic syndrome picture, nephritic proteinuria, albuminuria, then dysmorphic RBCs, RBC cast, all of that will help us to recognize the case, right? Then it can also be because of the tubular damage. When the renal tubules will get damaged, when there is decreased blood supply, ischemia, right? And extremely important cause, and nowadays it is one of the very important causes, that is sepsis. Most of the patients who are in the ICU with sepsis, they have some impaired renal function. It is mostly because of the tubular damage. Then nephrotoxic drugs, for example aminoglycosides, they can also cause tubular damage. Okay. Then vascular, right? Tubules are receiving the blood supply, and if there is a vascular pathology, we can develop tubular damage like vasculitis. We have a long list of conditions where we discuss vasculitis in rheumatology. Then I think yesterday or some other day we spoke about the conditions where the platelets are reduced because of increased consumption destruction. One of such example is thrombocytopenic thrombotic purpura or hemolytic uremic syndrome. And malignant hypertension is one more condition where we can have tubular damage. So when tubular damage happens acutely, we also call it as acute tubular necrosis. Acute tubular necrosis. What is important for the exam going student is how to differentiate between a patient with pre-renal acute kidney injury and acute tubular necrosis. Now you may say, sir, why is it not a big concern to differentiate between acute glomerulonephritis and pre-renal AKI? Bilkul nahi. The presenting pattern is very different, right? For example, acute glomerulonephritis, these patients will present with, right, what we call as, they will present with nephritic picture, right? Nephritic syndrome. So they will have periorbital edema, proteinuria. Along with that, they will have the dysmorphic RBCs. They will have the RBC cast. All of that makes it very clear for us to identify. Vascular disorders, again not very difficult because there are various other manifestations. Like vascular patients might have they might have the Raynaud's phenomenon and other vasculitic symptoms, right? Malignant hypertension, not difficult because the blood pressure will be high, the papilledema on the eyes will be visible. So what is difficult for us to distinguish is the acute tubular necrosis and pre-renal AKI, and how to differentiate between the two is the MCQ topic. Okay, so we will go there, but before that, one question. If I get to see a patient today, right, all our definition of acute kidney injury says rise in creatinine by some value, right? Rise होना चाहिए, but to say rise मतलब मुझे पहला baseline value पता होना चाहिए. If I see a patient with creatinine 2 today and I don't know his previous creatinine value, then how would I know whether it is recently increased to call it as acute or whether it was elevated for several months, several years? How would I know? So first thing, when we have abnormal renal function test reports, right, your relatives, whoever is showing an abnormal report, first thing is that you need to differentiate whether it is an acute kidney injury or whether it is chronic kidney disease. And what is the best investigation that helps us to distinguish between acute kidney injury and chronic kidney disease? This is an MCQ and the answer is imaging. Imaging, the best method to differentiate between AKI and chronic kidney disease is imaging, and the most convenient imaging method is going to be ultrasound. Ultrasound, because ultrasound, see, X-ray में तो kidney नहीं दिखेगा, right? Either you have to go for CT scan, MRI or other more advanced imaging, or ultrasound. Ultrasound is convenient, right? Cost effective, non-invasive and safe. That is why if anybody asks you what is the best investigation to differentiate between AKI and CKD, ultrasound. How ultrasound will help us to differentiate? In acute kidney injury, there are no structural changes in the kidney, right? 2 दिन में, 3 दिन में, 4 दिन में kidney का shape, size नहीं बदल जाएगा. But in chronic kidney diseases, the structural changes will be visible on the kidney, right? So in normal kidney, how does it look like? When you look at the kidney, right, you will notice that kidney has a medulla and a cortex, and we can clearly see the medulla differentiated from the cortex. So a normal kidney has corticomedullary differentiation. It has corticomedullary differentiation. So in acute kidney injury, we will see that they will have retained corticomedullary differentiation because sufficient time is not there for the structural changes. But the abnormal image that you see here, right? In this image, you can't point out where is the cortex, where is the medulla. Second thing, you will notice that the size of the kidney has shrunken. So in CKD, it will be abnormal, where you will have shrunken kidneys, the size is reduced, and you will have loss of corticomedullary differentiation. Nowadays, whenever a diabetic patient goes to a physician, he will ask for the ultrasound of the kidney, and when the report comes, the first thing he will be seeing is what has happened to the corticomedullary differentiation. अगर differentiation blur हो चुका है तो इसका मतलब है patient has already developed the chronic kidney disease. Differentiation is retained, then probably he is normal or he may be having acute kidney injury अगर creatinine ज़्यादा है. Okay. Now coming to the main point, how to differentiate between acute tubular necrosis and pre-renal acute kidney injury, right? तो उसके लिए एक small table है for comparison, but let me ask you a question. Normally physiology क्या है? किडनी में यूरिन फिल्टर होता है at the glomerulus. We filter the urine at the glomerulus, and then once we filter, right, we reabsorb most of the things back, right? Water we reabsorb, sodium, right, other electrolytes we reabsorb, right? Whatever only unwanted substances like creatine, the urea, we will not reabsorb. We will excrete reasonable amount of it, right? But most of the essential things like glucose, sodium, we will reabsorb, right? Where the reabsorption happens? Filtration happens at the glomeruli, right? Reabsorption starts in the proximal convoluted tubule and then goes on all the way to the collecting duct, right? Water reabsorption to collecting duct में भी होता है, right? Now if I have a pre-renal acute kidney injury, means what? The blood supply to the kidney would have reduced. That is what pre-renal acute kidney injury means, right? In such cases, circulating blood volume is less. In such cases, what do you want your kidney to do? Excrete more or reabsorb more? Reabsorb more water or excrete more water? Why pre-renal happens? Because of reduction in the circulating blood volume, hypovolemia or reduced cardiac output. Basically, kidney को कम blood मिल रहा है. In such cases, right, kidney should reabsorb more water or excrete more. Just take an example, right? From morning till evening, you have not taken much of liquids or water, right? In the evening, you will have dilute urine, you will have profuse urine, or you will have little and concentrated urine. We will have little and concentrated urine, right? So whenever the blood flow to kidney comes down, kidneys recognize that the circulating volume has come down. So they will reduce the excretion of water. They will reabsorb most of the water, right? And please remember that they will also reabsorb most of the sodium, because if the circulation, the blood reaching the kidney has come down, it also means that the probably blood pressure is on the lower side. So increase the blood pressure, it is better to reabsorb sodium. So they will reabsorb sodium and water maximum. So what you excrete is going to be concentrated urine, right? Okay, clear? Now let me say glomerulus was fine, right? The blood supply was fine, glomerulus was fine, and we have filtered the urine, but the damage is in the tubules. If there is damage in the tubules, will I be able to reabsorb? Because reabsorption होता कहाँ पे है? Tubules में, right? Reabsorption happens in the tubules. If the tubules are damaged, will I be able to reabsorb water and sodium? No, right? So I will end up losing a lot of water and lot of sodium. Whenever there is a damage to tubule, we lose sodium, we lose water. When there is a pre-renal acute kidney injury, we will maximally reabsorb sodium, maximally reabsorb the water, right? That's the basic point. So with that point, it is very easy for us to construct this table. There's a table comparing the two, pre-renal and acute tubular necrosis. Pretty easy. Okay. First one, urinary sediment or CAS, right? So in pre-renal AKI, there is no structural damage to kidney. What kind of cast we will see? Only the normal cast, which is going to be hyaline cast. But in case of the acute tubular necrosis, we just learned that in tubular necrosis, whatever tubular cells that are shed, they get impregnated on the hyaline cast and form what we call as renal tubular epithelial cell cast, or in simple words epithelial cell cast. यही अगर ट्रैक्ट में बहुत दिन रहेंगे तो they will also become muddy brown cast because of the lipofuscin pigmentation accumulation. Next one is the urine specific gravity. Pre-renal में क्या हो रहा है? We are absorbing maximum amount of water and maximum amount of sodium, right? So when we absorb a lot of water, what will happen to the urine that we are excreting? It will be concentrated. So if it is concentrated, what should be the specific gravity? It will be high, right? So that is why we have relatively high specific gravity of the urine whenever we have pre-renal AKI. But if there is a damage to tubule, I am not able to reabsorb water, right? So in that case, I am losing a lot of water in urine. The urine will be dilute. So what will happen to the specific gravity? It will be less, right? The specific gravity will be less than 1.020 if I have a acute tubular necrosis. Pre-renal means urine specific gravity will be high because we will have concentrated urine. So all you need to remember is when you think of pre-renal, think of concentrated urine, and when you think of acute tubular necrosis, think of dilute urine because reabsorption tubules में होता है. Damage to tubules means you are not reabsorbing. Okay. Then urine sodium, right? Whenever we have pre-renal AKI, means less amount of blood is going to the kidney, right? That means the amount of pressure delivered to the kidney through blood is also low. So it will always lead to activation of renin-angiotensin-aldosterone axis. And then comes the aldosterone, which will stimulate the kidney to reabsorb sodium. So whenever we have the pre-renal AKI, there will be maximum reabsorption of sodium. So when we reabsorb sodium, what will happen to the sodium in the urine? It will be less, right? So urine sodium will be less than 20 millimoles per liter in pre-renal AKI. It will be higher because we will not be reabsorbing the sodium. Absorption to tubules में हो रहा है. If the tubules are damaged, we will not be reabsorbing. So we will lose a lot of sodium in urine, and that is why the urine sodium will be higher in the acute tubular necrosis, right? And if you ask me, sir, all this तो ठीक है, लेकिन tell me one single test which is the most important one that I need to remember from this table, then my answer will be FENA. FENA refers to fractional excretion of sodium, means how much of sodium reached kidney, out of that what percentage got excreted in urine. Through the blood, how much reached the kidney, what percentage got excreted in urine. Let me say, just to give you an example, okay, 100 millimoles reached the kidney, out of that how much came in urine. So 100 millimoles reached the kidney and 1 millimoles came in the urine. That means the fractional excretion of sodium is 1%. So में से 1% excrete हुआ, 99% reabsorb हुआ. So in a patient with pre-renal AKI, we will be maximally reabsorbing. So we will be excreting less. So fractional excretion of sodium will be less than 1%. When it is more than 1%, means 2% or more than 2%, it means you are not able to reabsorb. You are losing it in urine, indicates that there is a damage to the tubules, acute tubular necrosis. Okay. Then urine osmolality is indirectly nothing but urine specific gravity. Specific gravity high hai, to osmolality will also be high, right? So that is what all you need to remember is concentrated urine for pre-renal AKI and dilute urine for the acute tubular necrosis. Okay. So now let me ask you a question. So I have a patient with increased creatinine, okay, and increased blood urea nitrogen, okay, and his fractional excretion of sodium is 3.5%. So what is the diagnosis here? Is it pre-renal AKI or acute tubular necrosis? Pre-renal AKI or acute tubular necrosis? I have already told you fractional excretion of sodium is the single most important test to differentiate between pre-renal AKI and acute tubular necrosis. Good. So when it is less than 1%, that means less amount of sodium excreted, maximum reabsorbed, it is pre-renal AKI. When it is 2% or higher, it is acute tubular necrosis. So this profile should indicate that we are dealing with a patient with acute tubular necrosis. Good, absolutely right. So what we have learned so far is we have learned how to define acute kidney injury using the KDIGO criteria, where we looked at the creatinine, right? Rise of creatinine by more than or equal to 0.3 milligrams per deciliter from the baseline within 48 hours, or more than 50% within 1 week, or urine output less than 0.5 ml per kg per hour persistently for more than 6 hours. That is the definition of acute kidney injury. Then we learned about the staging. The first one was the KDIGO staging, 1, 2, 3, creatinine 1.52, right, 1.9, 2 to 2.9, or 3 times the baseline, that is stage 1, 2, 3, or urine output 0.5 ml per kg per hour or like lesser than that for 6 to 12 hours, more than 12 hours, or 0.3 ml per kg per hour or less for more than 24 hours, or anuria for more than 12 hours. That is our 3 stages. Referral criteria is nothing but stage 1 is risk, right? Stage 2 is injury, and stage 3 is failure. Agar failure persist karta hai for more than 4 weeks, it is the loss, and if it is persisting for more than 3 months, we call it as the end stage kidney disease. Okay. Yeah, urine output is absolutely the same parameters in the referral criteria also. Okay. So then we learned that the causes for AKI can be divided into pre-renal, where there is reduced perfusion of the kidneys, renal, where there can be damage to glomeruli, tubules or blood vessels, and post-renal, which is mainly because of the obstruction, maybe because of the renal stones or because of the urinary bladder cancer, right? Now coming to how do we manage pre-renal, the most important thing that makes a difference and helps the recovery is the hydration, because there is reduced perfusion of the kidneys. So maintain the good perfusion of the kidneys, the functions will increase, right? Typically you have loose stools, severely dehydrated, and your kidneys have shut down, right? Hydrate, the kidneys will bounce back. Apart from that, treat the underlying cause. If it is renal means glomerulonephritis, we have specific treatments, right? Like some cases we need to use steroids, some cases we need to use the immunosuppressant depending on what is the cause, right? If it is acute tubular necrosis, again just treat the underlying cause, whichever is responsible, we have to treat it. And if it is post-renal, it is generally because of an obstruction, and the only way we can treat it is relieve the obstruction. How to relieve? If there is a stone, we can basket it and remove it. If there is a bladder cancer, we have to consider surgery. Not possible, then alternate ways to relieve the obstruction. Okay. Now what complications acute kidney injury can lead to? It can lead to uremia, means increase in blood urea levels, right? Is that a big problem? If urea level is high, what problems it can lead to? High urea levels can lead to what we call as uremic encephalopathy, means it will affect the functioning of the neurons, and we will lose the ability to concentrate, and patients can get into coma, and it can lead to death. We call that condition as uremic encephalopathy. Not uric acid stones. See, uric acid is different from blood urea. When we say uremia, we are referring to elevated blood urea, not the elevated uric acid. Okay, so uremic encephalopathy, that is where you get one sign, right? What sign am I demonstrating? If I ask a patient of CKD, this can be a question, right? They say that, okay, there's a patient with CKD who came to the emergency room, and he was in altered sensorium. He was asked to outstretch his hands like this, and then when he was asked to outstretch his hand like this, these kind of movements were noticed. What do we call this as? In fact, there was an FMGE, last FMGE question exam, they had given one image of a hand like this, and they had indicated the movement. What is this called as? Right, it is a tremor, but what kind of tremor it is? It is called as flapping tremor, right? So in uremic encephalopathy, we can see flapping tremors. Patients can have flapping tremors. Flapping tremors are also called as asterixis, right? Then high urea level can also cause pericarditis. We call it as uremic pericarditis. Uremic pericarditis, right? Then it can also cause hemolysis. Hemolysis means it can break down your RBCs. Okay. Then acute kidney injury can also lead to decreased excretion of potassium, leading to hyperkalemia. And hyperkalemia can give rise to tall T waves on ECG. Tall T waves on ECG, right? Then wide QRS complexes. The QRS becomes wide, T waves become tall, and apart from that, most severe form, it causes something called as sine wave. Sine wave. These are the three findings that you should be aware of when you talk about hyperkalemia. And then all of us know that kidneys play an important role in regulating the acid-base balance. If I disturb the kidney function, I can develop metabolic acidosis. So these are the three important complications of acute kidney injury. Okay. Now coming to the next and the last important topic, that is chronic kidney disease or CKD. What is important from this topic? Number one, you need to know the causes. Some MCQ points are there, but most importantly, you need to know the staging of the chronic kidney disease and complication. That is where I am anticipating MCQs. We will begin with the causes. What is the most common cause for acute kidney injury? Whether it is India or rest of the world, 60% of the patients who have been stamped as a case of CKD are because of diabetic nephropathy, or in simple words, diabetes. Diabetes mellitus is the leading cause for CKD worldwide, right? It accounts for 2/3 of all CKD cases. 2/3 of all CKD cases are because of diabetes, and the second most common cause is hypertension. Hypertension. We call that as hypertensive nephropathy. So diabetic nephropathy is the leading cause. Hypertensive nephropathy is the second most common cause. This accounts for around 20%. 2/3 is roughly 60%, right? Another 20% are because of hypertension. And there is a trivia here. Trivia in the sense, hypertension can lead to CKD and CKD can lead to hypertension, right? So if you have hypertension that led to CKD, CKD will cause further worsening of the hypertension. Okay. What are the other causes? Chronic glomerulonephritis, drug abuse, SLE, what causes called as lupus nephritis. These are all other causes. The other causes list is long, not important for us. MCQs, they will ask what is most common and what is the second most common. Okay. Now anticipated topic is staging of CKD. Okay. Now CKD, the staging, we follow again the KDIGO guidelines, and according to that, each patient with CKD is tagged with two numbers. The staging is not single. Like we had stage 1, 2, 3 for the acute kidney injury. Here we have 5 stages, but those stages also have an additional number, right? So we have two numbers for staging. One is GFR based, which is usually abbreviated as G followed by which number it belongs to, and the second one is proteinuria based, where we will look at the degree of proteinuria and categorize the patient as having A1 proteinuria, A2 or A3. Right? We will do an exercise of this staging for us to understand it better. First, let us start with the GFR based. Okay. So we will say the normal GFR is around 120 or higher, right? So when the patient is called as having stage 1 CKD, his GFR is still close to normal, 90 or higher. It is stage 1. When it drops to 60 to 89, it will be called as stage 2. Then stage 3 is where it is dropped further. Stage 3 is further divided into two groups, 3A and 3B. 45 to 59 we call it as 3A, and 30 to 44 it's called as 3B. Then when it is 15 to 29, means less than 30, right, up to 15, we call it as stage 4. And if the GFR is less than 15, we call it as stage 5. There are few points to learn here. Any patient on dialysis, for whatever reason you have started the patient on dialysis, he will always be counted as stage 5. If there is an acute kidney injury patient who is started on dialysis, he will always be counted as stage 3. Clear? Okay. Now why this staging is important? Staging will not only help us understand how much the patient's kidney is functioning, what is his GFR, it will also help us predict certain complications. For example, CKD induced hypertension becomes evident in stage 2. CKD causes anemia, that becomes evident in stage 3. Okay. CKD causes neuropathy, nerve dysfunction, that becomes evident in stage 4. So we can not only understand how much kidneys are functioning, we can anticipate कि हाँ इस stage में ये complications can become evident. Okay. Then each patient of CKD will have some degree of proteinuria. and that proteinuria will further be staged, right? A1 refers to less than 30 milligrams per day. That is, as we know, is normalcy, right? 30 to 300 milligrams per day will be counted as A2, and more than 300 milligrams per day will be counted as A3. This table I want you to by heart, and just for us to understand it better, let us do an exercise. Okay, so we will have one number, and I want you to give the stage for this patient, right? The patient's GFR, estimated GFR is 48, and his urine albumin creat ratio, or the 24-hour urine protein, is 150 milligrams per gram of creatinine, or in other words 150 milligram per day, 24-hour urine creatinine. Okay, so now what should be the stage of this CKD? GFR wise, right? What should be the GFR stage for this patient? As you look at, it is 48, so it fits into 3A. So GFR wise it is 3A, right? But what about the urine output, the urine albuminuria or proteinuria wise? Should be A1, A2 or A3. Should be A1, A2 or A3. 150 milligrams falls into A2, right? So this patient's stage will be reported as the 3A A2, or in simple words 3A A2. 3A A2. So please practice this. This is going to be useful for our day-to-day practice as well as answering the MCQs. Straight out they can ask you a question, giving you the details, and then ask you which stage it is. Okay. Now, having learned that, we will progress to understand the complications of chronic kidney disease. What are the anticipated complications? Yes, urea is cleared by the kidneys, right? And why clearance of urea is important? Because normally when proteins or amino acids are metabolized, right, we end up producing ammonia. Ammonia is highly toxic to neurons and various tissues. That's why this needs to be excreted. This cannot be easily excreted because kidneys are not very efficient in clearance of ammonia. So then this ammonia instead goes to liver, and liver takes the burden of converting this ammonia to urea. So in the liver, ammonia becomes urea with the help of a cycle that you have studied called as urea cycle. Urea cycle runs in the liver, and then liver converts ammonia to urea. Now we have urea in circulation. This urea will be excreted by the kidney in urine. Kidney in urine. That is how we clear. But if my kidneys are dysfunctional, then the urea levels start increasing. Urea is also not a safe substance. Ammonia is toxic. Urea is also toxic. Only difference is we have difficulty in efficient elimination of ammonia by the kidneys, but urea can be easily excreted. So as long as kidneys are fine, I will be able to clearing whatever amount of urea my body generates. But if kidneys lose function, the urea levels will start increasing, and as we have learned, urea is toxic, right? And what all problems it can cause? As we have learned, it can cause uremic encephalopathy, it can cause hemolysis, right? It can cause uremic pericarditis. And please remember, if I have a patient with CKD where uremic symptoms are there, right? If symptomatic, how would I treat? If symptomatic, in the sense if I have encephalopathy or pericarditis, or I think I have already told you, severe nausea, vomiting, all of these are indicating symptomatic uremia. How do we treat? It is not easy for a doctor to treat uremic symptoms, because see, another function that kidney does is excrete the water, right? Eliminate urine, water in urine. If kidneys are not able to sufficiently eliminate the water in urine, I am retaining it, that's why I am developing edema, I can still give you diuretics, right? So whenever there is fluid overload because of reduced kidney function, I can treat it with diuretics. When diuretics do not help, right, then I would think of dialysis. Then there can be electrolyte abnormalities in kidney, because kidney decides how much sodium to be excreted, how much potassium should be excreted. But if there are dysfunction, we can have hyperkalemia, and I can have hyperphosphatemia. Phosphate levels can increase, hyperphosphatemia. But for all of them, we have easy way to treat, right? When we have hyperkalemia, how do we treat? The initial treatment will be, we can give insulin. Insulin shifts the potassium from extracellular compartment to intracellular. Whatever potassium is there in the blood, that gets transferred into the cell. So the blood level of potassium comes down, right? We can also give salbutamol nebulization. That will also help transfer of the potassium from extracellular to intracellular. Then there are potassium binders. There are substances which bind the potassium and make us lose that potassium in the stool. We ate, we got the potassium, but we do not absorb, we lose it in the stool. There are ways, right? Only when these measures, collectively called as anti-hyperkalemia measures, fail, then we go for the dialysis. So dialysis is a last resort when it comes to hyperkalemia. So when my phosphate level is high, right, I would rather put the patient on dietary phosphate restriction. I will stop him from eating phosphate in large quantities, right? And then I can also give phosphate binders. If that also does not help, then we go for dialysis. Okay, but if urea level is high, there is no easy way to get rid of urea. So if the patient is symptomatic, it should always be started on dialysis. So any patient with symptomatic uremia requires dialysis. That's the take home message. Okay. Then CKD can cause anemia. One of the MCQ that is frequently asked on this is, what are the reasons for a patient with CKD to develop anemia? So can anybody tell me what all reasons are there for a patient with CKD to develop anemia? What are the reasons? First and most important reason is the deficiency of erythropoietin, because erythropoietin is produced by the kidney, right? Decreased erythropoietin, and this is the single most important reason. This is the single most important reason. Apart from that, when you have chronic kidney disease, right, you will have severe nausea and vomiting because of the uremia, right? You will not be able to tolerate food well. You can also have hemolysis because of uremia, right? So uremia leading to decreased appetite and hemolysis. Decreased appetite means you eat less food, you eat less iron. Okay. Then third, patients with CKD are at increased risk of bleeding. They often develop erosive gastritis. That also contributes, right? And fourth one, CKD is a chronic inflammatory disorder. So you will have increased interleukin 6 and interleukin 1. Okay, these will inhibit iron absorption. This is what happens in your disorders called as the anemia of chronic diseases, where there is decreased iron absorption because of interleukin 6 and interleukin 1. These two substances also suppress bone marrow. So all these mechanisms are involved in the pathogenesis of anemia of CKD. Repeatedly they ask which of the following mechanisms are involved in the anemia of CKD. They will give 3 of the lists I have given, and one of the option will be all of the above. All of the above would be your answer. But if they ask you to pick up the most important one, it is the erythropoietin deficiency. Okay. Then we have an entity called as CKD related mineral bone disease, or CKD-MBD. The cortisol levels in CKD patients, yes, in the initial stages during dialysis, generally the cortisol levels shoot up, but the long-standing CKD patients may have milder degrees of cortisol insufficiency. In fact, any chronic disease can have the cortisol insufficiency. Okay. We will study a little more detail on the CKD mineral bone disease because that's an important MCQ topic. Apart from that, the last point I want to make it clear here is that there is increased risk of coronary artery disease. There is increased coronary artery disease risk, and coronary artery disease is the most common cause of death in patients with CKD. Majority of the patients with CKD today are well managed by dialysis and transplantation, but still the mortality rate is high because of coronary artery disease. They have accelerated atherogenesis, so rapidly atherosclerotic plaques accumulate in their blood vessels and then we end up losing them. Okay, so if they ask you what is the most common cause for death in CKD, it is not uremia, it is not hyperkalemia, it is not hyperphosphatemia, it is the coronary artery disease. Okay, so few points about the CKD related mineral bone disease. I'll start with the basic pathogenesis. See, normally what happens when you have CKD, your kidneys play a crucial role in excretion of various electrolytes like potassium, calcium, phosphate. The most important thing here is the phosphate. So once we develop chronic kidney disease, right, we will not be able to excrete the phosphate. So we will have decreased phosphate excretion. And because of that, the blood phosphate level starts increasing. We develop hyperphosphatemia. So whenever we have CKD, we develop hyperkalemia, hyperphosphatemia. Okay. The increased phosphate levels, right, is known to stimulate the parathyroid hormone production. It is mediated through a substance called as FGF23. It will stimulate the parathyroid gland to produce more parathormone. Right? Another important change happens in patients with CKD. We know that conversion of inactive vitamin D, right, to 1,25 dihydroxycholecalciferol, or the active form of vitamin D, is done by the kidneys. Right? So one level of hydroxylation happens in liver, and the second hydroxylation reaction happens in the kidney. So if the kidneys are dysfunctional, we will not be able to create sufficient quantities of active vitamin D. This 1,25 dihydroxycholecalciferol is what we call as the active form of vitamin D. And we know that vitamin D is required for the absorption of calcium from the intestine. So if the vitamin D levels decrease, then I will not be able to absorb sufficient amount of calcium from the intestines, from my food, as well as calcium reabsorption from the kidneys. So that will lead to decreased calcium levels, or in other words, hypocalcemia. That is also a stimulus for the production of parathormone. So parathormone levels in patients with CKD increases. Now what should I call it as? Primary hyperparathyroidism or secondary? Primary or secondary? Primary is when gland itself is overactive without any stimulus. Like I have a parathyroid adenoma tumor which is secreting lot of parathyroid hormone, then it is primary. यहाँ पे there is a stimulus present. What is the stimulus? Increased phosphate level and decreased calcium level. These stimulus are there. So this is a secondary hyperparathyroidism, right? Secondary hyperparathyroidism. Now the job of this parathyroid hormone is to stimulate kidney to excrete more more phosphate, so that it comes down and reabsorb more calcium, so that the calcium level increases, right? Apart from that, the parathyroid hormone will also go to the bone, and what it will do to the bone? Your blood calcium level is low. Parathyroid hormone's job is to increase the calcium. How can it increase? Go to the bone. There is reserve or store of calcium. Take that calcium from the bone and put it into the blood. That is how the blood level increases. So the bone level of calcium will start decreasing, right? That's what this hyperparathyroidism will do. So to give you a summary, when we have secondary hyperparathyroidism, there will be increased bone turnover. We are removing a lot of calcium from the bone. This leads to plenty of manifestations. What manifestation we can expect? There will be decreased bone calcium, and it can lead to what is known as osteitis fibrosa cystica, or OFC. It's a condition where there is increased bone turnover leading to brown tumors in the bone, because the osteoclasts are all accumulating in the bone to increase the turnover. Osteoclasts are the ones which will remove the calcium from the bone. So if they accumulate in one region, it looks like a tumor. That's what we call as brown tumor, or osteitis fibrosa cystica. Okay. So there can be two image-based questions from this increased bone turnover state in CKD. So if you get a question where there is a patient with CKD and you see this tumorous appearance on any of the long bones, it is suggestive of osteitis fibrosa cystica, or what we call as brown tumor. It indicates that there is accumulation of plenty of osteoclasts in the region, right? Apart from that, the clearance of the calcium from the bones in the vertebral bones can give rise to a particular sign called as Rugger-Jersey sign. So here when you look at this point, right, the calcium loss you can see here, right, there is a significant loss of calcium. You can see the rarefied bones here, significant loss of calcium, and this kind of looks like the the jersey t-shirt, right? So we call this finding as rugger jersey spine. Rugger jersey spine. They can ask you where these findings are seen, and they can also ask you by giving you a story of a patient with CKD and then giving this image, and then they will ask you what is the problem, right? So basically rugger jersey spine and osteitis fibrosa cystica are seen in any patient with secondary hyperparathyroidism, and one of the leading cause for secondary hyperparathyroidism is CKD. Now if I have to manage this patient, what should I do? How can I manage this patient? How can I manage? Yes, if I somehow control the phosphate levels, right? This is the most important stimulus for hyperparathyroidism. Then I can manage the condition, right? Similarly, if I somehow increase the vitamin D activity and calcium levels in the blood, I can suppress this parathormone production, right? So I have to reduce the phosphate levels, increase the calcium levels. How can I achieve that? Restrict the phosphate intake in the diet or give drugs which will reduce the phosphate absorption, and then give calcium supplementation, give vitamin D supplementation so that the calcium level increases. That's the way we treat most patients with CKD, right? Hyperphosphatemia, we treat it with dietary restriction to less than 900 milligrams per day, and then as phosphate binders we can give calcium acetate, or there is a drug called as sevelamer. I want you to remember this because this has been asked, which of the following is a phosphate binders used for the treatment of hyperphosphatemia? The answer is sevelamer. So when you take the sevelamer tablets, it binds to the phosphate that we have taken in the diet. So instead of that phosphate getting absorbed, it gets lost in the stool along with the sevelamer. Okay. Then the second problem was hypocalcemia and hypovitaminosis D, that can be treated with vitamin D and calcium supplementation, right? And then one more thing that we can do is, if I can tell the parathyroid gland ignore this hypocalcemia, right? If I can tell the parathyroid gland that ignore the hypocalcemia, that so that it does not produce the parathormone. Why is it producing? Calcium low hai, so that is why it is producing. But if I trick the parathyroid gland to believe that the calcium is sufficient, then I will not produce this extra parathormone. This extra parathormone will not cause the damage to bone, right? How can I trick the parathyroid gland to think that the calcium is normal? So the parathyroid gland, right? Parathyroid gland has specific sensors. So on our parathyroid gland, we have sensors for calcium. We call them as calcium sensing receptors. We call them as calcium sensing receptors. Calcium sensing receptors present on the parathyroid glands. So whenever the calcium levels decrease, these glands sense, they get activated, stimulate the parathyroid gland to produce parathormone. But if I use a substance, right, which can keep the calcium sensing receptors to believe that the calcium level is sufficient, then they will not send the signals to the parathyroid gland to secrete more parathormone. So these kind of drugs are what we call as calcimimetic agents, which stimulate the calcium sensing receptors. There are two drugs, etacalcide and cinacalcet. They are stimulants of the calcium sensing receptors. Again, this is an MCQ. Which of the following is a calcimimetic or a calcium sensing receptor stimulant, and where is it used? It is used in patients with secondary hyperparathyroidism. Unnecessarily parathyroid gland is secreting too much of parathormone, causing the clearance of calcium from the bone. So if I trick the parathyroid gland to believe that calcium is insufficient, so it will not clear the calcium from the bone. Okay, clear? Now the last complication is the anemia of chronic kidney disease. I have already told you it is multifactorial, but the most important cause is decrease in erythropoietin levels. Now a patient with CKD, if he develops anemia, right, how do I treat? One, as I have already told you, they have decreased appetite, nausea, vomiting, so they may be having iron deficiency. Replace it, and erythropoietin deficiency requires erythropoietin replacement. There are two forms of erythropoietin that is available. One is the natural form of erythropoietin, we can give it in the injection, or we have a recombinant or a synthetic form of erythropoietin called as darbepoetin. Today darbepoetin is the preferred agent because of its high efficacy and longer duration of action. Because of its long duration of action, it can be given once a week, right, or once in 2 weeks. So we don't need to give it more frequently. The erythropoietin requires twice a week or higher frequency of administration. So this is more effective in increasing hemoglobin level, and it is more requires less frequent administration. The only problem with these erythropoietin replacement therapies is erythropoietin, as the name says, yes, it stimulates the RBC precursors and stimulates more RBC and hemoglobin production, but it has some effect on the platelet production also. So erythropoietin stimulates the platelets also. Platelets can increase and it can lead to increased risk of thrombosis. This question has been asked, and that is why I have written it down. Use of erythropoietin is associated with increased risk of thrombosis. The last MCQ point that they would ask you is, okay, you have a patient with CKD who has developed anemia and you started them on the treatment. Now, should I take his hemoglobin to normal, which is 14 to 15 grams per deciliter, or no? The answer is no. Because when you try to take the hemoglobin to 15 with erythropoietin, invariably you will end up developing clots in deep veins. So that is why sufficient hemoglobin is what we target, not the normal hemoglobin. And what is sufficient? Around 11 grams. This is also an important MCQ point. What is the target hemoglobin to be achieved in a patient with CKD? Around 11 grams per deciliter. No need to reach the normal values, right? So that's it from me here today, guys. I'm leaving you with some of the important MCQs for you to address from whatever we have discussed. The notes will be available on the PW MedEd Telegram, and if it is taking time, I will immediately post it on my individual Telegram channel, which is called as Dr. Patil's Medmania. If you search it on the Telegram, you will quickly get it, and within next 2 to 3 minutes, the notes will be available there. The previous class notes, some of you were inquiring, I will load it there. Okay, so see you tomorrow, guys, and from tomorrow we are getting into the core of medicine. So we'll start with cardio, neuro, and the respiratory medicine. See you tomorrow, same time, 4 p.m. All the best, guys. See you. Bye-bye.